introduce our next Master of Arts in Maternal Child Health Systems candidate and her presentation, Jodilyn Owen.
Thank you. Can you hear me okay? Great. So I want to start by acknowledging that I'm sharing my work with you today from Memphis, Tennessee, originally territory of the Chickasaw people who were forced to leave their land during the Great Removal on what was called the Trail of Tears. The Chickasaw were widely known for their highly developed social and ruling systems, as well as their artistry. I think before I share my work, I want to share my gratitude for this program, which allowed me, even at my age, to re-enter the world of formal education and to engage in graduate level learning and discourse. Learning is the music of my life, and this program has been an incredible symphony for me. Thank you to the leadership of this department and to Nancy and Karen, the visionaries of this program, for your investment in the future of maternal child health systems, and to the educators who taught and mentored us through this experience, and especially to Karen for guiding me to think expansively, take care of details, and delight in the path we all share. I want to thank my cohort. A pandemic, 2 hurricanes, a deep freeze, unimaginable losses, barriers, and Zoom. None of it was any match for us. The force that you have been in my life is immeasurable. And I hope we get to keep learning with, from, and about each other far into the future. A deep thanks to the sister of my heart, Tara Wall, who believed in me and pushed me to reach out and grab this dream. And finally, thank you to my parents who waited a very long time for this, but never stopped. Never stopped believing that I could. To my husband, who has been my greatest collaborator for the past 28 years and knew that I would. And to our children who said that I should. I'm so grateful for it and love you all. My project is called From Siloed to Seamless, an interprofessional education curriculum and for midwifery and medical students to advance knowledge, practice, and collaborative skills. These are our learning objectives for the day, and I want to wish a happy Father's Day to those that are celebrating. Today, we're going to define interprofessional collaboration, also called IPC, and interprofessional education, also called IPE, where we will identify some common barriers to IPC, describe the benefits of interprofessional education to maternal child health systems, and describe an overview of IPE curriculum that can be implemented by midwifery and medical education programs. So I'm really just going to share a story with you today. This is a story that starts with my great big idea that was totally, completely, and utterly wrong. I've spent my career working in and observing the impact of our fragmented maternal child health system and trying to reconcile that with my own deeply ingrained belief that people should be able to easily access a system built on a platform of equity that works in connection for them. Even early on in my doula work, when I was supporting families as they had to traverse the distance between providers, I held in my mind a vision for how this could all work together. And I've always had complete clarity about this and worked to establish partnerships in my private practice in South Seattle as part of a larger clinic in Memphis and in deep formal partnerships inside the organization I co-founded, Rainier Valley Community Clinic. I decided to get my master's degree to learn more about how the maternal child health system functions and to explore pathways to move those pieces closer together. As you likely know or have experienced, there is an enormous workload that pregnant and new parents hold as they walk the distance from midwifery to physician care. There is the explaining of the care they've chosen, and then there is a forced justification for those choices. And finally, the heavy, heavy lift of asking for help from disapproving providers. We have a great tool in use to close this gap during labor called smooth transitions, which at minimum opens up lines of transfer for care during labor, crucial to the safety of birthing families and the midwives who serve them. My big idea was to deepen and expand this across the perinatal year and to move from simple referrals to a system where providers walk towards each other to reduce the distance a patient has to walk on their own, to understand and support each other's goals, keeping the patient at the center, to get out of our silos and run towards each other like a slow motion sequence in a made-for-TV film. And obviously came my next thought, and that great big totally wrong idea that I could create a toolkit to help obstetricians and pediatricians take this walk and receive midwifery consumers with an informed mind and kind stance. So I started my literature review looking at interprofessional collaboration, and that's the space where licensed providers come together in deep engagement, working to achieve shared goals. Now, I believe deeply in collaboration, and my mind is just a very, very human mind. It is susceptible to the most human of traits, which is to see what we believe we will see instead of what is actually there. So as I was reading and reading and reading, and yes, I read all of these papers cover to cover, it took me a minute to come to terms with what the literature, no matter how I coded it, showed. And that is, as it turns out, that by the time we achieve licensure, there are some well-established roadblocks that prevent us from working with each other. These barriers are called clefts, cysts, and silos, and they exist around the world between physician types, physicians and nurses, physicians and allied health professionals, nurses and midwives, physicians and midwives, and among allied health professionals and all of the providers they refer to. If you can just hold this in mind or carry it forward for a few minutes, this really underpins why it is not tempting at all for maternal child health providers to try to find a new way to work with each other. We are constantly beset by this heap of reasons to hold steady. Once I understood this, once I accepted it, and I stopped fighting with the literature, I understood clearly that any toolkit I might develop would be crushed beneath this heap and never get used. Because the literature is clear. Once we are working with post-licensure professionals, there is a positive reinforcing feedback loop that keeps us in our silos. It is painful to wander out. However, there was a beacon of light, one singular group that does collaborate well in the US, pharmacists, who, as it turned out, provided the most important clue for me. Pharmacists are great collaborators because they start learning with other health professions and building the skills needed to effectively collaborate right from the start of their education. Using these clues from the adjacent field of pharmacy, I took a second look at maternal child health systems and specifically the relationship between midwives, obstetricians, and pediatricians, the three provider types that feature prominently during the perinatal year. The relationship is remarkable for the length and depth of the cleft between them and the pure commitment and energy they or we all pour into maintaining that space within all involved professions. And here the literature showed that patients are left to traverse that cleft between providers on their own. Having chosen to utilize the services of a midwife, patients may not disclose their decisions during medical visits, knowing that physicians have stereotypes and judgments about midwifery care. But they may also be nervous about asking their midwife for access to or discussing physician care and recommendations, because midwives may also lean on stereotypes of physicians. And no matter how we look at that, as a cleft, as a cyst, or as a silo, maternal child health providers have perfected the art of keeping ourselves insulated. And this has a cost to the families we serve that matters deeply to me. When I talk about love and justice in healthcare being one thing This is what I'm talking about, our responsibility to reduce that cost for parents, for babies, and for community. Learning to collaborate is more than learning to share resources or just network. It is about establishing shared goals, sinking into a team mindset, and knowing and owning our own roles and responsibilities while promoting those of our colleagues. What I learned is that in order to actualize a world where maternal child health providers are turned towards each other and working deeply with each other, we must build a platform where we are first learning with, from, and about each other from early on in our programs of education. Interprofessional education, known as IPE, moves participants from perceptions, assumptions, and stereotypes to beliefs that reflect the experience of learning technical and collaborative ideas and skills with each other. And starting this process at the start, at the entry level, has tremendous benefits. Once I got onto the trail of interprofessional education, I could finally establish my project aims. My literature review ultimately discussed the history, benefits, barriers, and roles of IPE for midwifery education. It examined programs and outcomes in the literature, and finally reviewed options and recommendations for curriculum design and implementation. For aim number 2, I was planning to create a 3-year, 9-unit curriculum that would be covered across 3 years of school. But the recommendation from experts, which makes perfect sense if we think about it, was to create the more advanced workshops in collaboration with cross-sector authors. So I focused on year 1 and wrote a 3-unit curriculum to be delivered over 1 year. And aim 3 was to seek advice and perspectives about that curriculum from multidisciplinary expert reviewers and then revise it as indicated. As I read for my literature review, I kept coming across this organization, the Interprofessional Education Collaborative, with 21 health professions represented, including nursing, pharmacy, optometry, public health, allied health professions, physician's assistants, respiratory care, physical therapy. But there is no explicit listing for maternal child health associations, for obstetrics, for obstetricians, pediatricians, or midwives, affirming my findings that maternal child health systems have perfected the art of avoiding learning with, from, and about each other. More than what I learned about this collaborative is what I learned with and from them. I was able to attend a 4-day intensive where participants were guided through a variety of pedagogical theory and skills and workshopped the development of IPE sessions. This was a transformative experience for me. I went into it worried how I would be received as the first licensed midwife to attend one of their programs, and especially worried if I would be able to keep up. But this community truly exemplifies spirited collaboration. They welcomed me, gave generously of their time, and were curious and excited about the ways that community-based midwifery practices might become hubs for living IPE labs. Out of this experience, I learned that IPE units are always developed around increasing these 4 competencies for students. So competency 1 is values and ethics of interprofessional practice. 2 is understanding roles and responsibilities. 3 is interprofessional communication. And 4 is teams and teamwork. Curriculum is designed at 3 progressive levels relative to students' experience in IPE settings: novice, intermediate, and near licensure. I'll go back to that. There we go. I decided to focus on novice level, where the goals are to build confidence in collaborative skills and use adaptive learning theory to layer some intentional behaviors and more complex approaches onto the basic skills students learn at the start of their programs. During the workshop, students actively coach each other throughout the program, and they have access to and guidance from faculty and facilitators, and they are not assessed on their technical skills. And we'll look at some examples of that shortly. But first, I want to share that the underlying theory of change here is that when you bring your future workforce together and add IPE into their educational experience, we graduate students who are ready both to practice and to collaborate. And this contributes directly to optimal health systems, delivery, and patient outcomes. I found this pretty exciting, very exciting, really. And I got to work writing a 3-unit IPE curriculum designed to be delivered over the course of the first year of midwifery and medical school. So this is the curriculum with, from, and about each other, a 3-unit interprofessional education cohort-based workshop series for novice health professions students. It's easily adaptable to include nursing and other professions. And one of the strengths in my approach at directing this for licensed or certified professional midwives and medical students is that those two professions represent the furthest ends of the MCH spectrum, of the maternal child health spectrum. And designing for the two furthest apart makes it easier to include programs of education that are in between them. The curriculum brings together 2 or more schools. Each school lends student and faculty champions who work with each other to adapt the curriculum to meet their needs, promote the workshop within their programs, and lead and facilitate their time together. Each unit is designed as a morning-long workshop to be followed by a prepared lunch for students and facilitators from all schools to share a meal and build social rapport with each other. And these are the 3 units. Unit 1 is building the team. Unit 2 is trauma-informed care. And Unit 3 is partnering with an interpreter. The curriculum packet includes 3 sections, and they're here: Module 1, Module 2, Module 3, and it includes all of the materials listed there. I reviewed each of those sections with a variety of experts, from physicians to midwives to educators and experts in delivering and evaluation of IPE in particular. And then I also spoke with medical, nursing, and midwifery students. I incorporated their feedback, and my final project reflects their suggestions. I do want to share a couple of interesting points of feedback. The first was a question around providing students with all of the background information ahead of time so that they can show up and apply their efforts to learn how to collaborate and the specific skills related to each session. So I made really extensive student prep packs so that they could get all of their technical learning out of the way and not feel like they were trying to grasp terminology and medical issues during this program, since we are focused on collaborating. And on the other side of that spectrum, there was a feeling that medical school is really about how hard you can make everything for students in order to continually push them into uncomfortable spaces. But the importance of ushering students cognitively to move past concrete concepts into adaptive learning lends to the idea of giving them the concrete in advance so that they can practice the abstract and adaptive applications in a well-supported environment. This is like a lot of jargon to say, if you feel prepared to do something, you're going to be able to advance what you're doing and grow in your work and in your service. And that's really the goal of these programs. The objectives of these workshops is to do that and to bring students in so that they can be in a space that is intentionally structured for well-supported peer and faculty coached low fidelity learning environments. But I want to say that the most interesting finding of all of these interviews that I did was that I asked everybody what the biggest barrier they see to implementing this program is in their setting. I actually asked for any barriers, but they all named the first one first. It was a universal answer. It was across professions, pre and post licensure, from first year students to retired nurse educators. And that was the worry that the other profession would not want to do this program with them. And this reflects what the literature says and drives home the point that we are actually keeping ourselves in these silos. So this is a snapshot. Each unit includes student preparation handouts, the run of show with all materials, including the PowerPoints with notes, facilitator directions, and pre and post evaluation. So each unit is, or each section is a number of pages long. I just took screenshots of sort of the front page to show you what it looks like. This is the building the team, and the run of show for building the team includes a shared PowerPoint presentation, and then we move into small group problem solving work. Each section is built out in the same way. So all of the units have this same rundown and help get facilitators and faculty oriented towards what to expect from the curriculum. This is the run of show for trauma-informed care, and it includes a PowerPoint presentation and multiple stations for small group activities. This workshop really focuses on increasing the confidence of learners and builds on their vital assessment and history-taking skills by asking them to conduct an assessment and medical interview using trauma-informed language and behavior. And this is the run of show for partnering with an interpreter. It includes a shared PowerPoint presentation and multiple stations where students work with standardized patients and interpreters. We focus on evidence-based practices and learning skills for the specific behaviors that providers fall short on the most often. All told, there are over 300 pages of student learning materials, run of show instructions, standardized patient and interpreter callouts, and small group rotation directions, and then our pre and post surveys. Future research includes an investigation to understand how governance, facility policy, stakeholders, institutions, and the work environment influence the ability of practitioners to collaborate in maternal child health education and practice settings. It includes creating universal curricula framework and evaluation tools in order to understand the impact of IPE on a broader scale across health profession schools, and studying cultural, racial, and full spectrum gender-based experiences of the ways that medical and midwifery students experience IPE. These are some next steps, which include adding finishing touches to the PowerPoint because it was the pandemic and we couldn't get all the photos of midwifery settings, and then submitting the curriculum for public use, loading all surveys into Qualtrics, and putting a management system into place. Working with cross-sector professionals to write years 2 and 3, and finally to engage in a discussion with the Midwifery Education Accreditation Council to consider IPE recommendations to their accredited schools of midwifery. There are a lot of reasons to engage in IPE. There are a lot of benefits to getting out of our silos, some of which are listed here, and this is only some. Ultimately, this is about the ways we provide a platform for students to learn with, from, and about each other, and the ways they will carry their skills into deeply collaborative, seamless service across maternal child health systems. Finally, I want to conclude with a picture of a baby who was the beneficiary of a team of providers who all believed in working with each other to help his mom and him achieve their best health. And the look on his face says it all. Thank you.
Thank you so much, Jodilyn. Just a moment for a round of applause. I see the Jodilyn fan club here, your family from all over the country. Your colleagues have all logged in. I will open the floor to questions in a minute, but Jodilyn, I just want to take a moment to acknowledge this was a tremendous undertaking for a PhD level project, and you took it on in a 1-year master's project. And I know you had to make some adjustments along the way and maybe drop some things that you had really wanted to do, but it is an incredibly impressive and profession altering body of work that you have produced. And I'm so proud of you for this accomplishment, and thank you for sharing it with all of us.
Thank you.
Questions or comments?
I would like to say that I am so excited about what you have created, and I would love to see this implemented in our midwifery program at Bastyr. And I'm looking forward to talking with you more about how we might move that forward into some next steps. It's incredible work.
Thank you, Wendy.
Andrea, I see you've got your hand up.
It's amazing what I can't know that you're working on, even though I'm talking to you every week and every couple of days. This is incredible. I echo what Jen has to say. And I have, I'm going to speak to the Meek part, although I can't speak for Meek now, but I'd say 10 years ago, Meek was talking about this, and and I'll speak back for myself. It was about the how. And that statement that you said about that every other profession thinks the other profession isn't interested is probably more what has informed my own insecurity about it, which is, oh, they would never do that with us. So the fact that you've put this together for everybody is incredible. And thank you. I hope I see it everywhere. And I wish I could go back in time and do my education again in your program.
Thank you. I think insecurity is like the key, because it wasn't just midwives that felt insecure. Nurses and like nurse educators who have many, many years of experience were like, I don't know if the midwives would do this with us. And the physicians were like, wait, midwives would do this? Everybody just feels a little insecure about getting to know each other because we've been so separated. And I think it's about just taking a breath and taking a step in towards each other and seeing what happens when we actually all get into the same room.
Jodilyn, a couple of comments in the chat and then a question. So a comment from Trinity. This work is so needed. I work within an FQHC, and yet all of our providers are so disjointed. Even when all of our departments are in the same place, we still struggle to collaborate. The world is better with you and your work in it. And another comment from Kristen Eggleston. It is so exciting to see something so interdisciplinary and perspective shifting.
Thank you.
And then there's a comment / question here from Karen. Jodilyn, I love the 3 topics you chose for the first year students. Have you thought about what you might cover in years 2 and 3? Would you maybe revisit trauma-informed care in year 3 when they can approach it in a more complex manner to try to cement this way of being a provider?
So yes, the way that this is designed, and in the IPE world, curriculum gets posted into like a hub, and all of it is posted in Word and PowerPoint. It's not PDF, so you can suck it down and you can make it your own. And I made recommendations in the curriculum for more advanced learning, but I think what happens when you come together with educators from the direct schools is that somebody who's educating 3rd-year midwives and 3rd-year medical students is going to have a direct understanding of what level they should be at, what kind of fidelity they need to demonstrate in order to be moved forward to get closer to licensure. And that is why the recommendation is to put those minds in the room to plan and write out this curriculum. So I had some ideas, but I also think that that the most important idea is that it can be built together, and that whatever it is that I think of as the best, or I guess that I thought of when I was doing this, I was having even a hard time choosing 9. I had like 18 ideas and I had to choose. But I think it's more important to sit together as a group and identify together as a group what we can think of, because I've seen when you put midwifery and medical and nursing minds in the same room, we lend really unique perspectives to the same topic. So I had about 18 ideas that I had to, but I don't know that any of them would actually be the ones that get through. So I look forward to building that out with folks from other professions.
Awesome. Jodilyn, a follow-up comment from Karen. Great, your process actually achieves your outcome. And then a question from Andrea. She would love to hear stories about its successes. Who is doing this well?
Who's doing this well is a really interesting question, because if you look on major university websites, you will see a lot of them have interprofessional education programs, like whole departments. But when you talk to people who are in those departments, it doesn't seem to be going so well. And the one exception that I found was the University of Arkansas at Little Rock, which is close to me here. And they have a lot of representation and leadership in that collaborative. And then we're the two of the three experts that I spent the most time with, both work there. One is in health literacy and one is the leader of that program. And they are doing it really well. They actually have 72 health profession schools in that campus that one IPE program manages. And the length of those schools is like 7 months to 7 years, but everybody is required to do it. And they have it mapped out so that students from across health professions meet each other over and over and over again throughout their experience. And, you know, one of the advantages of that is that they are in control of the schedule and the program. So they can stop all classes and send everybody into these IPE rotations, and they have the power to do that. And that gets harder to do when you have nursing, midwifery, medical students all trying to collaborate. Schedules is very, very hard. And that was one of the challenges. And especially with folks who are working hospital shifts, they have really weird hours compared to when a school is open. So finding ways to bring everybody together is a major challenge. And one of the solutions I identified was to do this as an intersession program. So a lot of medical schools and nursing schools have intersession education programs, and we'd probably aim to draw the midwifery students into that thinking.
Jodilyn, I have a couple of comments from the chat. The first one from Dr. Nancy Anderson to say, this is amazing work. As you know, I was a medical student. This curriculum would have really helped me and my colleagues to understand how to work with other professions. And the interprofessional fear factor is a very important point. It is an amazing bridge to the future that we all want to see.
Thank you, Nancy.
And the other comment comes from Dr. Christina Supitu-Plath, who says, many of the obstacles that prevent effective interprofessional collaboration are based on mutual prejudice between different healthcare professionals. Drawing from evidence on bias reduction in another field of weight bias, interventions tend to be most effective when offered to students in the healthcare professions, as opposed to healthcare practitioners and people in the general population. So I would like to applaud Jodilyn's initiative to focus on students in the healthcare professions very early on in their education. This is where we should concentrate our efforts to achieve sustainable change in the healthcare system.
Thank you. I had other experience writing curriculum that we thought was going to be appropriate for people who were at a certain point in their life, and learned over time that we had to get younger and younger and younger in order to get at at what we think about ourselves, as our internal sense of self shifts as we get older and we get informed by what other people tell us we should be thinking and believing. And this, I really could see this here. And I saw a lot of things actually pointing, even in my interviews, of some of the student midwives saying that they loved that there were pregnancy related cases in the practice sessions, because they felt like it would give them a leg up on the medical students who they were worried would run over them. So, and that's all their language. So that's already in our minds that medical students are somehow going to be more powerful in that setting than midwifery students. And it made me really think about pre-health professions. And there's some research to back this up, that, and I've shared this a little bit broadly, that I have a pipe dream of doing this with folks pre-health professions as a way to establish comfort and confidence in their ability to learn with, from, and about each other when we kind of don't even know exactly where we're going yet, even post high school. So there's some evidence for that, Christina. Thank you.
Jodilyn, I have a question for you. You had a lot of next steps, and I feel like there's a lot of ways you could go with this, like more curriculum development. What maybe after you take a break and come down from the stress of finishing a program while working full time. But what do you think your immediate next step will be for this work?
My immediate next step is to finish. I was working with one of the doctors who's a national expert in the evaluation of IPE. And part of those of you who write curriculum already know this, but part of what I really learned was how important getting the evaluation right first is. Thank you, Christina. And to this doctor who I've been working with. And I'll be continuing that work with him to solidify that. And there's no PhD in interprofessional education, or that's where I'd be going. So maybe an adjacent field, but we have a lot of ways of expanding and building out this program within our work setting and in our community. So I kind of hope to take some of it there. After a nap.
After a long, well-deserved nap. Thank you so much, Jodilyn. Any other questions or comments for Jodilyn? Yeah, Nancy.
I was just going to jump in off of something that you said, Jodilyn, which is the idea of beginning this kind of education before people start training in a specific field as a part of pipeline programs. Now, Bastyr, as we know, has made baby steps towards working with pre-professional programs. And I think, of course, doing more of that, but also keeping that kind of interprofessional engagement, or creating a component of interprofessional engagement for pipeline programs would really be important before people actually know really what they're going to do.
Yeah, I couldn't agree more. And I've talked a lot about making a baby midwifery program. And I think pipeline is a great, I mean, I love babies too, but pipeline is a great way to talk about that there's something that's really important that happens before you step into the pressure of midwifery or medical school, where your mind is still a little more open and the world feels full of possibilities. And I think by the end of the first quarter of those schools, students are already feeling crushed by the culture and the expectation of programs across professions. So this is not something that is unique to anyone, but we hear a lot from all the students that it's really hard to be in school. So catching them a little bit before that would be a great way to get them excited and also connected with each other.
Jodilyn, after your nap, Karen is offering PhD ideas for you in the chat. Sociology, education, medical anthropology, health services management. There are many disciplines who would love to have you and support this work.
Thank you, Karen. I'll call you.
Jodilyn, I have one more comment in the chat from a Miss Julia Owen. And she says, "Mom, this is so awesome. I can't believe, but can, knowing you, that you were able to put all of this together while also working so hard in the past year. As a nurse in a hospital-based setting, I can see how incredibly helpful this curriculum will be once you're able to implement it. Can't wait to see where this goes and how impactful it is on healthcare education and then on interdisciplinary work."
Thank you, Julia.
Tara, I see your hand is up.
I had to go after Julia because we get to sit on the sidelines and be your cheerleader and watch the behind the scenes of creating this amazing program. And I talk to you every day, just like Julia, and I still had no idea this was what you were doing and what you were up to. And so I am just so proud of you, of the work that you do, and how how much time and intent that you put into this project. You've blown away so many barriers within access to care for students of color in the midwifery world. And to be able to see you just destroy all the silos that are happening between us is just so refreshing, and it's so amazing. I'm so proud of you. You've worked to really build these bridges between so many different disciplines this year, while you were working full-time in a practice as a clinical director, while there's a pandemic, and while you had so many pressures on top of you. I'm so excited for the future for you and for what you're going to do and how you're going to take this to the next level. And I'm going to continue to be your cheerleader and see and just watch the amazing things that you're doing. Thank you so much for your love, your sacrifice, and for so much that you're offering to all of our professions. So I love you so much. And I'm so proud of you.
Thank you. Oh my gosh, thank you so much.
Okay. It's always going to be impossible to follow the daughter and the colleague with so much love. So I will simply say thank you, Jodilyn, and thank you for this tremendous presentation. Your excitement is palpable and it invigorates the whole community. So thank you for that. And if folks don't have any other questions or comments, or if you think of some later, we can catch Jodilyn again, hopefully. But otherwise, we'll take an extended lunch here and plan to come back at 1 o'clock. So Wendy, I don't know, are you gonna reopen the Zoom or just leave it open and folks can filter in and out?
Yeah, I'll just leave it open. And for those of you who are not in the Pacific time zone, that would be in about an hour and 18 minutes from now. So Pacific time zone right now is 11:42. We'll plan to come back at 1 o'clock Pacific. Adjust accordingly based on your time zone. And we'll look forward to seeing you back here in a little over an hour. Well done, everybody.
Hey, Andrea, do you want to do your tech check now? Or do you want to come back? Hold on, you have to unmute yourself. Sorry.
Yeah. No, because I made 2 notes that I wanted to add.
Okay, that's
Can I
fine.
just do it 5 minutes before?
Yeah, you bet. I'm actually gonna run and pick up bakery items for our party tomorrow in this little gap of time. So I should be back in plenty of time to do that. But if I'm not, I know that Wendy will also be holding the space and you can do a tech check with her as well.
Yep, I'm here.
I have to set up my other monitors and stuff too. So great. I'll see you.
I'll see you soon.
Okay. Bye.
Bye.
vision, always at home. Home for a living. Do you know how I always have a feeling? Always gonna be that one in a million. Always at home. Home for a living. Shooting for the stars, money make a killing. Do you know how I always have a vision? Always at home. Home for a living. Do you know how I always have a feeling? Always gonna be that one in a million. Always at home. Sometimes I get a feeling, yeah. I get a feeling that I never had before. No, I get a feeling, yeah. Oh, sometimes I get a feeling, yeah. I get a feeling that I never had before. No, I get a feeling, yeah. Yes, I can. Y'all better leave on with this plan. Pull me, grab from the book, you can't have me. I'll be the president one day. Yeah, could be first. When you like that concept, like you the one drinking what God said. Not gone. Now I got a word for your tongue. How many rollers songs you want? Yeah, I got a brand new spirit. We get it done. Roll up on the side of the bed like I'm born. I'm like the rhythm of shit to that sun. Deep dive in the US to Taiwan. I want to say that. I want to play back. I want to talk with the people when I hate that. I'm a body boy. Let's pay back. I got a feeling in the rap. ASAP. Sometimes I get a feeling, yeah. I'm feeling that I never had before. No, I get a feeling, yeah. Oh, sometimes I get a feeling, yeah. I get a feeling that I never had before. I get a feeling. The mountains high, walk on water. I got power, feel so royal. 1 second, I'ma strike for you. Diamond platinum, no more for you. Never adrenaline, never giving in. Giving up's not an option, gotta get it in. Witness, I got the heart of 20 men. No deal, go to sleep in the lion's den. Let go, that's far and crown. You're getting the king of the jungle now. Strong as ever can't hold me down. I'm in the mouth, gonna come and finish this round. Straight game face, it's game day. See me running through the crowd, feeling they lay. No trick plays, I'm Bill Gates. Nigga jeans, I'm on the same page. Sometimes I get a feeling, yeah. I'm feeling that I never had before. No, I get a feeling, yeah. Oh, sometimes I get a feeling, yeah. I get a feeling that I never had before. I get a feeling. Let's get it. I know you got to feel it. Let's get it. Gotta love the life that we living. Feeling, cold one Tuesday. I'm looking tired and feeling quite sick. I feel like there was something missing in my day-to-day life. So I quickly opened the wardrobe, pulled out some jeans and a t-shirt that seemed clean, topped it off with a pair of old shoes. I ripped around the seams. I thought these shoes just don't suit me. Hey, I put some new shoes on and suddenly everything's right. I said, hey, I put some new shoes on and everybody's smiling. It's so fine and don't show up on me for a long time. So it's rolling in the sweet sunshine and I'm running. I don't need an excuse to wear it my graduation. Woke up late one Thursday. I'm seeing stars as I'm rubbing my eyes, and I felt like there were 2 days missing as I focused on the day. Then I made my way to the kitchen. I had the stuff from the shock of what I found. A room full of other bad friends all dancing round and round. I thought, hello, new shoes, bye-bye, new. Hey, I put some new shoes on and suddenly everything's right. I said, hey, I put some new shoes on and everybody's smiling. It's so fine and don't show money for a long time. It's rolling in the sweet sunshine and I'm running late and I don't need an excuse to wearing my brand new shoes. Take me wandering through these streets where bright lights and angels meet. Stone to stone, they take me on. I'm walking till the break of dawn. Take me wandering through these streets where bright lights and angels meet. Stone to stone, they take me on. I'm walking till the break of dawn. Hey, I put some new shoes on and suddenly everything's right. I said, hey, I'll put some new shoes on and everybody's smiling. It's so inviting, no short money for a long time. Slowly strolling in the sweet sunshine and I'm running late and I don't need an excuse to wearing my brand new shoes. Oh, hey, I put some new shoes on and suddenly everything's right. I said, hey, I'll put some new shoes on and everybody's smiling. It's so inviting, no short money for a long time. Slowly showing in the sweet sunshine and I'm running late and I don't need an excuse to wearing my brand new shoes. Yesterday's gone. Yesterday's gone. Running in the night times to come. Another things that you've done. If your life was planned for you, just think what tomorrow will do. Don't stop thinking about tomorrow. Don't stop. You'll see. You may fall. Yesterday's gone. Yesterday's gone. All I want is to see you smile. If the text just a heart, no, you don't believe that it's true. Never meant any harm to you. Don't stop thinking about tomorrow. Don't stop. Simply yesterday's gone. Yesterday's gone. Don't stop thinking about tomorrow. Don't stop. Simply yesterday's gone. Yesterday's gone. Don't you
You're broken down and tired of living life on the merry-go-round. You can't find a fighter, but I see it in you, so we can walk it out. Ooh, mountains, we can walk it out. And mountains. And I rise like the day, I rise unafraid, I rise up, and I do it 1,000 times again. And I rise up, I like the waves, I rise up, in spite of the age, I rise up, and I do it 1,000 times again. The silence isn't quiet, and it feels like it's getting hard to breathe. And I know you feel like dying, but I promise we'll take the world to its feet. Mountain, bring it to its feet. Mountain, and
times in the good. I have to celebrate you, baby. I have to praise you like I should. I have to celebrate you, baby. I have to praise you like I should. I have to praise you. I have to praise you. I have to praise you. I have to celebrate you, baby. I have to praise you like I should. I know you moved on to someone new. Hope life is beautiful. You were the light for me to find my truth. I just want to say thank you. Leaving to find my soul. Told her I had to go. And I know it ain't pretty when our hearts get broke. Too young to feel this old. Watching us both turn cold. Oh, I know it ain't pretty when two hearts get broke. Yeah, I know it ain't pretty when two hearts get broke. I hope someday we'll sit down together and laugh with each other about these days, these days. All our troubles we'll lay to rest and we wish we could come back to these days, these days. These days, these days. These days, these days. 3 years of ups and downs, nothing to show for it now. And I know it ain't pretty when the fire burns out. Calling me when I'm drunk, remind me of what I've done. I know it ain't pretty when you're trying to move on. Yeah. I hope someday we'll sit down together and laugh with each other about these days, these days. All our troubles we'll lay to rest and we wish we could come back to these days, these days. These days, these days. Cigarettes in the ashtray, reminiscing on those past days. I thought you'd end up with my last name, but I had changed. And I traveled around the world, think where you living at now. I heard you moved to Austin, got an apartment and settled down. And every once in a while, I start texting, write a paragraph, but then I delete the message. Think about you like a pastime. I could call you a river, get you baptized. I wasn't ready to act right. Used to always think I'd get you back right. They say that things fall apart. We were gonna move to Brooklyn, we were gonna stay hard. You know, this is the tool to remind us who we are. And that we are not alone, we're walking in the sun. I hope someday we'll sit down together and laugh with each other about these days, these days. All our troubles, we wish we could come back to these days, these days. We wish we could go back to these days, these days, days. When I wake up in the morning, love, and the sunlight hurts my eyes, and something without warning, love, bears heavy on my mind. Then I look at you, and the world's all right with me. Just one look at you, and I know it's gonna be a lovely when the day that lies ahead seems impossible to face. When someone else instead of me always seems to know the way. Then I look at you, and the world's all right with me. Just one look at you, and I know it's gonna be a lovely when the day that lies ahead of me seemed impossible to face. And when someone else instead of me always seems to know the way, then I look at you, and the world's all right with me. I just want to look at you, and I know it's gonna be a lovely